My name is Eric Nottmeier. I'm out of Mayo Clinic, Florida. I'm co-chair of the section on robotics and navigation here at NAS.
Hi, I'm Stephen Pirris. I'm a neurosurgeon in Jacksonville with the Ascension Medical Group. Also plan to do some work at Mayo Clinic, and I live in Jacksonville. So a quick question for you, Eric. What do you think about the current status of navigation versus robotics, and how are they linked?
Well, you know, navigation in the past has maybe about 15-20% of spine surgeons have used that. And some of the data we're seeing here at NAS in the abstracts is that a lot of residents coming out have been trained in navigation, and so they're starting to use it more and more as they get out into practice. So we may see an uptick in the percentage of navigation users coming up in the next 5 to 10 years. And so navigation may penetrate the spine surgery world with a little bit more percentage as we see the future come up. What do you think of the current state of robotics now, the technology, and what it's accomplished?
So robotics right now is in its infancy. Right now there are several different robots on the market. They're FDA approved. But right now the main focus is for placing pedicle screws. And they utilize navigation systems to help them perform their tasks. There are a lot of processes being made to further the field of robotics, and in my opinion, there's going to be many parallel processes. Now, of course, they can't be parallel because they all eventually have to converge, but where the future of robotics is going to be is where the robot's actually doing part of the case. Right now, it would be a cobot rather than a robot, and we need it to be a robot if it's really going to be efficient. And so I think we're going to get less invasive. We're going to have the radiology side, where MRI is going to be able to better delineate bone and soft tissue so the robot can recognize it. And there are MRI sequences on the way that, that they're different from the current routine MRIs. The navigation systems are going to have to improve to get from 3 millimeters accuracy to hopefully within 1 millimeter accuracy. You're going to need to find ways to get the bone removed by the robot, and that's going to be whether it's better drill technology or ultrasonic technology. We also need to figure out how to get the soft tissue removed. Is it going to be the current paradigm of tearing and grabbing tissue, or is it going to be something new that comes off that emulsifies the tissue? And then you have to put it all together and include hemostasis. And until that comes together and all these silos converge, then we'll have our process where I think most people want the robotic field to go.
Yeah, I agree with that. I think when I'm using navigation to put screws in, I'm also using navigation beyond that in the case for, sometimes put the inner body cage in and navigate in patients who have previous laminectomies to try to stay out of the dura. And, some of the current robotic systems do allow navigation beyond the screw placement, some of them don't. And so when we look at the cell phone and how that has progressed from this big bulky phone back in the 90s and in the bag phones to what it is today, I think the robot is going to be on that path. It's probably going to be a little bit more accelerated in its development. I can see the first stage of that would be the robot putting in screws while the surgeon is doing the laminectomy and decompression portions of the procedure, where the robot is just working around the surgeon, putting in screws. So you can have some concurrent actions in the OR. It may decrease OR time. Eventually with bone removal, and that's going to require a high degree of accuracy. And I think that's one of the hang-ups now, is maintaining patient registration accuracy, especially if you're going to have someone doing a laminectomy while the robot's putting screws in. The robot's going to have a continuous feedback loop on where that patient's spine is in 3D space. And once we master that technology, then the door is wide open for further development. In terms of navigation, I do think that where we're seeing some advances in the field is not necessarily navigation systems themselves, but also with the intraoperative imaging, the cone beam computed tomography, the CBCT devices out there now, such as EOARM, and Zeem has one. Are efficient. Globus has just come out with intraoperative CBCT device. Some of these systems, it can be hard to penetrate the upper thoracic junction to place T1 and T2 screws. Other systems you can. It seems like the more powerful the CBCT device is, the less mobile it is. And so, we've had cases at our institution where we may have had one O-arm or two arms, and this O-arm's going from room to room. It's pretty mobile, but it seems to be the more mobile the system, the less power it has. Has that been your experience too?
Yes, because there's also, with BrainLab, they have a higher quality imaging system, but might not be quite as mobile as some of the other systems that you were just describing. So they're always finding that balance, and then you also have to consider radiation exposure, and taking into account the radiation exposure to the patient preoperatively and intraoperatively, and how to find ways to get the patients registered into the navigation system to maintain the accuracy. Because that seems to be where most of the problems with the current robotic platforms run into issues, is sometimes the registration cannot be quite as seamless from their preoperative study to the intraoperative registration, and then you can end up with screws that are deviated, and that can't happen if you're doing a decompression. We don't want to take part of the bone off that we don't want to take off, and that's where the next steps, again, safety first is going to be the key for this development, and that's probably where the process might not go as fast as we all want it to be, because it has to be incremental and it has to be safe, and I think we will get there, but it's going to take some time with all these processes to work themselves.
I agree with you. You can be 1 or 2 millimeters off on a screw and not have a disastrous consequence. But when you're talking about bone removal with robotics, if you're 1 or 2 millimeters off, or the drill goes a little bit deep, and you get caught up in the dura, that can have a very significant adverse result. And so, in our symposium yesterday on the robotics and navigation section, someone asked a question, it was a very good one, about the radiation exposure to both the patient and the surgeon. And, we've demonstrated in the publications we put out at Mayo Clinic, Florida, that there's virtually no radiation exposure to the surgeon when you're using navigation. But that does bring up the question of radiation exposure to the patient using intraoperative CBCT as compared to the standard fluoroscopic techniques. And so the question came up, would MRI ever be a reasonable alternative for navigation and robotics in terms of the registration and the intraoperative pre-op scans that you get? And I think it will be. The advantage is you're going to have no radiation exposure to the patient. Disadvantage is you're not going to get that bony type of detail that the CT gives you. But I think as technology advances, we will eventually transition to MRI. Other options out there, ultrasound, intraoperative ultrasound will give you real-time dynamic feedback from the patient, and so I think these are just the potential avenues to expand into as the technology develops.
And so there's a lot of interesting things going on. This field of navigation robotics, in my opinion, is going to be the future of spine surgery, and it's going to be very exciting. NASS has thousands of members, so what does the Navigation Robotics Committee have in store for helping educate these members coming up in future meetings?
Well, yeah, as given the fact that navigation is being more and more widely used with the residents that have been trained on it and coming out, we are going to have a pre-meeting course at the annual meeting next year, and it's going to be navigation and robotics, and we'll have to see. The future will tell us, if one or both of those technologies reach a ceiling, or if they continue to expand and develop their capabilities.
And we also have a webinar that shows the current status of some of these technologies, and that webinar will be added onto in future year or in future months as well.
And we did do a recent webinar over the past year that will be on the NASS website, for 2 or 3 years, and is accessible to any of the members.